Yo, it's Seabass. In a few short weeks, I will be a PGY5 nephrology fellow. Over the course of this academic year, I've been on inpatient consult service for 40 weeks, and I've easily seen over 400 new consults. If new consults were stacks, you might say I have stacks on stacks on stacks. Or perhaps you would say that I have racks on racks on racks. Suffice it to say, I have some words of wisdom regarding calling consults that I would now like to share with you. Let's go!
Kidney Bass Tommy.
Alright, let's start with the logistics. I used to think that the logistics, the nuts and bolts of calling the console, those were the boring bits, and so I would kind of blow past them. Now, though, I appreciate the logistics for probably being 80% of what's important when you call the consult. As an intern, I got fixated on presenting some curious clinical conundrum to the consultant, something they could sink their teeth into. Thank you for this interesting consult. Quite the platform to wax poetic about elitist esoterica into the electronic medical health record. No. Definitely not what it's about. Fundamentally, when you're calling a consult, you're asking for the consultant's help. And the best way to ask for help is to do so concisely and clearly. Here are the 5 steps you want to make sure you take in order to do that. Number 1, when you place the order, you want to make sure that you're simultaneously calling and texting as well. This seems a little redundant if your institution already has a built-in way to do this, but many institutions don't. And so that creates a problem in which the consultant may receive an order for a consult, and they're out and about on morning rounds for several hours, and then they don't realize that they've gotten the consult because they didn't receive a text or a call until they get back to their workroom several hours later. Avoid this. It's highly irritating to be on the receiving end of it. Just make sure that you're placing the text or the call to the consultant simultaneously with the order. Number 2, immediately identify that you're calling a consult and ask the other person on the end of the line if they're the correct party with whom you should be speaking. Don't mince words. Don't say things like, I want to get you on board. Just say, I'm calling a new consult. Are you the ex-consultant? Are you the right person I should be talking to? Number 3, identify yourself, the service that you're calling from, and make sure that there's a callback number readily available. Telling the consultant what service you're calling from already puts the consultant in the frame of mind of triaging that consult. For instance, at my institution, the renal service is super busy and has actually 4 or 5 separate teams that are in part geographically based. So if you're calling me automatically and telling me that you're in an ICU that's in a certain part of the hospital, I automatically know that I need to be sending that consult to a certain one of my colleagues. This basic information about where you're calling from is helpful for that reason. Number 4, say the patient name and their bed number. If the consultant is in front of a computer, then they're just going to pull the patient up immediately and follow along with you for the rest of the time that you're on the phone together with them. If they're not in front of a computer, what it allows them to do is, if they're conveniently located proximally to where this new consult is, they can zip off and see the patient quicker, expediting your preliminary recs. Number 5, label the hashtag medical problem and or procedure that you're calling about for the consultant. So this is a really huge point that I was taught while I was training during my first 3 years of internal medicine residency by Dave Simel at the Durham VA. There's this culture in internal medicine and other disciplines, for that matter, contemporarily, where we will often talk about a patient with this wall of text to say every nuanced detail of their medical and surgical history before we say the reason that they showed up to the hospital in the first place. You don't want to bury the lead. Instead, get rid of this possible problem by just starting up front with the main hashtag problem that you're calling about. So for example, if I'm a kidney consultant, I want to hear all the quick logistical data to immediately be followed by, and I'm calling about acute kidney injury, and I'm calling about considerations for initiation of emergent dialysis. Boom, that's it. You take out all the extra stuff about whether or not they had their RCA triple jail stented 13 years ago, and that background stuff gets pushed off, and it only will be provided to the consultant if they ask for it. Let's recap the 5 logistical steps one more time. Number 1, make sure that when you place the order for the consult in the computer that you're simultaneously placing a call or a text to the consultant. Number 2, don't pull any punches, just label up front that you're calling a new consult for the consultant. Number 3, make sure that you say your name and the service that you're calling from. Number 4, make sure that you say the patient's name and their bed number. And number 5, immediately follow this information with a hashtag medical problem or a request for a procedural consideration before you launch into all of the background stuff about their medical history. Let's finish up by saying a few words on framing the consult question. Sometimes you can get away without a consult question. This is why I was so careful to define those 5 steps in the logistical rundown. That's because step number 5 really emphasizes that you need to have a hashtag medical problem or a request for consideration of a procedure. Sometimes this can be sufficient. You might call me up and say, CBAS, I got this guy here with community-acquired pneumonia, and he is ESKD, Monday, Wednesday, Friday, and we plan on admitting him to the inpatient service. And then I'm going to say, dope. That's it. You're done. So that's sufficient. Consult questions are like appetizers. You don't need them, but they're usually nice to have. So what's the golden rule of framing the consult question? It's pretty straightforward. Just be as specific as possible when you're asking the question, and then pause. Let the consultant do the rest of the heavy lifting. They can elicit from you what other information they need by asking follow-up questions. Here's an example. CVAS, we got this lady. She's a young woman who's coming in with a number of signs and symptoms that might be consistent with the systemic vasculitis, but we also know that she has nephrolithiasis and think that her hematuria could possibly be explained by that. We're calling you because the specter of a glomerulonephritidity has been raised and want to know whether or not you think that the benefits would outweigh the risks for consideration of biopsy. Do you have any other thoughts for a serologic workup that we might send to round out our differential diagnosis? Gucci. Super specific. Then, as the consultant, I can ask some additional follow-up questions if I need to. The last thing I want to say about consult questions is if you're a July or August intern and you're listening to this, don't let your senior off the hook. So multidisciplinary rounds can be a very busy thing sometimes, chaotic with multiple moving parts and sometimes very sick patients. So if you're not clear about what the consult question is, ask your senior or your attending to clarify, since you're usually the one who ends up having to call the consult. Those are my thoughts on framing the consult question. If you made it this far in the video, you are a legitimate champion. Why stop now? Turn up with more kidney content up here or over here. Thanks again for watching.